Welcome to the Future of Dermatology podcast. I'm Dr. Farah Kamangar. What you're about to hear is a standout session from this year's SF Derm Conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
But now I'm going to take a sort of quick view of what I think are sort of the hot spots in our evolving perspectives on atopic dermatitis. So we do a lot of clinical trials and study and assist with study design for pretty much every product that's been approved for atopic dermatitis and other diseases down in San Diego. And we know we have our variation of atopic dermatitis from a baby with severe disease up into adults with significant atopic dermatitis who can be 60, 70 years of age. And we have this set of therapies that are coming in to help us to take care of them. So my big sort of punch list of the overview is that we have new topical agents. So non-steroidal agents, there's been a response in the industry for our desire to have more topical non-steroids. Roflumilast as a PDE4 inhibitor is approved now as the 0.15% formulation that's been approved for atopic dermatitis for ages 6 years of age and older. The 0.05% lower strength cream studies are long done. That's been done in 2 to 5 year olds, and we'll see if that gets labeled probably pretty soon. And they've started their under 2-year-old studies as well. Tapinarof, the same formulation is approved for psoriasis, is now approved from ages 2+ with long-term safety data as well. Topical ruxolitinib, we've had approved for a few years for vitiligo and for atopic dermatitis. And they've done studies down to age 2 as well. Expect labeling in the next few months, and they've had extended safety data as well. And even topical crisaborole, which we've had around for a while as a PDE4 inhibitor, a few years ago did a study where instead of doing BID application for 8 weeks, they then rolled over patients who got clear to 1 year, once a day application to affected areas and showed incredible safety as well as some efficacy with that as well. And then systemic therapy is probably the biggest change in atopic dermatitis. And that seriously, our experiences with that, we're still in what I'd say the clinical discovery phase. Because our experience, especially with treatment of younger children under age 2 in particular, we're still into every 6 months is a different experience because it's only been a short period of time that we've had that into our hands. And in our younger kids, to be truthful, our prior use of cyclosporin, methotrexate, azathioprine, et cetera, was always very, very minimal. We never had approval in the US, and we didn't use it that much. And the side effect profile was such that we didn't liberally use those in younger children, even with pretty severe atopic dermatitis, and that's a tremendously changing situation. So lebrikizumab, we've now had approved ages 12+ into adulthood. Tralokinumab is approved 12+ as well. Extended experience with our JAK inhibitors, both in adolescents and in adults with safety data. Dupilomab, both data on remission with Dupilomab, and then some studies I'll highlight in terms of impact on development of atopic comorbidities with the use of Dupi. Now flipping over to topical care. Still, much of our care of atopic dermatitis is topical care. My spiel does not change when I'm talking to patients. What are we going for? It's just what I say. I'm going for minimal rash, minimal itch, and minimal sleep disturbance. We decide if I can do that with topical, if I need to move over to systemics, that's the goal. Now, so I have a 7-year-old with atopic dermatitis, moderate eczema on the face, neck, antecubital fossa, little on the popliteal. Mom says, we use topical steroids, it comes under control, but I stop and it comes back. And they've tried TCIs and it burns, so what are the options? So the answer is that you have lots of options. You might do topical steroids intermittently, or you might try TCI again, or now you have these other agents, including 2 different PDE4 inhibitors, and the new ones having less stinging and burning. You have tapinarof, aryl hydrocarbon receptor agonist. 7-year-old, not yet, topical ruxolitinib, but you might have that within a few months. So there are these options that you have that are coming on and more on the way. Before I go to the new agents, I want to talk about topical corticosteroids. And to be truthful, I tell my patients, part of my discussion is that for me, topical steroids are like hammers for eczema. And I tell them I got mini hammers, like 1% and 2.5% hydrocortisone. I've got work hammers, like triamcinolone 0.1%, and I've got sledgehammers. And certainly for younger pediatrics, we're not using clobetasol regularly because we know at that point you start to overdo it. But we're in a funny situation with topical corticosteroids because we spend much, at least I spend much of my day sort of defending topical corticosteroids. And because I spend much of my time defending topical corticosteroids, I don't know if I necessarily look at the downside of them as much as we might, because we know more potent topical corticosteroids, you induce barrier dysfunction. You can have these systemic effects. There are these long-term questions. Katerina Abuera has raised issues in terms of, we know that there's impact on osteoporosis from the disease. Is that influenced from either topical systemic corticosteroids over time? Isn't known. Cardiovascular effects, certainly, but they're highly cost-effective. But our perspective on topical corticosteroids is really different than patients' perspectives. And certainly there's been this incredible social media influence discussion about topical steroid addiction. How many people have had a patient come in who is concerned about topical corticosteroid addiction in their practice? Okay. How many think they actually had it? Had at least one patient who's had it? Because they exist, they're out there is topical steroid withdrawal, but the phobia as compared to the amount of patients who we see with that is incredibly different. I have given half-hour talks just on topical steroid withdrawal syndrome. I'm not going to do that now, but I do want to point out that in the ether of information and in some articles, there's discussions about what the typical pattern might be for topical steroid withdrawal. Very commonly, there's a cutoff sign that's associated with it. You get these cutoffs in areas which otherwise we'd have allergic contact in the differential diagnosis. You get this incredible proliferative exfoliation, see it, and what's called elephant wrinkles, which people believe probably is because they're highly edematous and then they lose their edema at some point and they end up with this wrinkling size. It's controversial in the literature because there really aren't set criteria for what topical steroid withdrawal is, and it's been loaded with language of addiction. The topical steroid addiction is, and the problem with topical steroid addiction as language is that the solution that's posited by many of the, quote, experts is withdrawal from all medicines. They actually say you may have to quit your job and hang out in your house for a year or two to reboot and get better, even though there's no decent evidence that that isn't a reasonable response to it. So it's confusing in terms of patients, in terms of topical steroid risks. They're not as high as they may be fed by information. And we do have an evolving literature. So we defend topical corticosteroids at the same time, be aware of families' concerns with them. There was a recent article in the JID that talked about what's thought to be a pathophysiologic mechanism of topical steroid withdrawal. I call it science-y in quotes, because it's really a pretty terrible article. I shouldn't say that, but and when it came, they did a clinical part of the study, clinical study on atopic dermatitis without using standard outcome measures, with a control group of atopic dermatitis undefined who didn't have topical steroid withdrawal. So it's an issue. If you read that paper, it's really tricky, but they posit that there may be ways to treat it based upon their use of metformin might be useful, and I'll just say it's an unknown. Let's move on to what we do know is that we do have new non-steroidals that have been put into our hands and will continue to be expanded in ages. So tapinarof, a very fascinating molecule, right? So arohydrocarbon receptor agonist. It's been approved down to 2 years of age. It impacts on T-resident memory cells. They had Rachel Clark do these studies showing how tapinarof worked for that. It reduces oxidative stress. That's sort of how this ligand system works in the system. And it's been shown useful for atopic dermatitis. Their clinical studies were in moderate to severe patients. Average body surface area of 17% in a topical. So pretty impressive, about 45% clear or almost clear with Q-day application. They did an 8-week time course. That's tapinarof. I don't have the time to go through the long-term data, but the long-term data were really quite good from a safety standpoint, and they were using it as needed. So, how do you use it in clinical practice? Okay, all of the topical studies are tested as monotherapy as compared to vehicle with no other drugs. In clinical practice, you can mix and match in many different ways, but it's nice to have the data. In their long-term 1-year study, when patients cleared, they had a 75-day average time clearing off of their topical medication. Okay. Roflumilast, I pointed out already, has a 0.15% approved for ages 6+. They did a 4-week outcome with about 30% of patients making it clear, more to clear, so a little bit more modest results. Their 52-week study showed very good safety, very high tolerance with this product. Very interestingly, they went to a proactive model. So if patients cleared, they went to twice-a-week application of the drug, once a day, twice a week. And they showed that those patients maintained clear or almost clear for a median of 281 days. So if you are responsive to this, you can go to this proactive model with a high level of success in it. And the 0.05% studies, we've already published the data, not yet approved, down to 2 years of age, probably will be approved very shortly. It's a lower strength formulation, just trying to get around concerns about high body surface area, because there won't be a limitation of body surface area for that.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.